So good morning, everyone. Actually, good afternoon, everyone. So I'll be talking about total hip arthroplasty in acetabular fractures and what we need to prepare for going for such surgeries. So we all know that acetabular fracture is not a single type of fracture. It is an agglomeration of 10 types of fracture. And again, these 10 types of fracture present at various stages of intervention, such as an acute, a delayed THA, or a delayed THA in an operated case. So if we do, it's like a 10 to the power 3, around 1000 type of combinations you can get. So there are various scenarios that requires an arthroplasty. So a patient presents with a hip arthrosis, avascular necrosis, some non-reconstructable comminuted fractures. There may be an extensive impaction or a full thickness abrasive loss of the cartilage, or there can be an associated fracture of the femoral head or the neck. And there are many challenges also. The anatomy is completely distorted. There are multiple and large bone defects. There is scar tissue and fibrosis in neglected fractures. There is possible necrosis of the wall, posterior wall. There are multiple fragments which do not allow primary stability. There may be a malunion, a pelvic discontinuity. There will be previous screws, plates that come in your path. There may be a mild infection and of course an osteoporosis. And the implant challenges, you have to deal with the bone loss, which may be a segmental or a cavitary defect. And then there is always an unstable cup floor, a pelvic discontinuity or a combination of all of the above. So the first armamentarium that I want in my OT is a multi-hole acetabular cup. Now these cups are made up of tantalum or titanium. These are highly porous metal cups and they allow multiple screw hole directions. So you get a good purchase in whatever bone stock you have got, and these also osseointegrate faster than regular cups. Now this is a case, a clinical picture. The blue arrow, these are the superior and the posterior purchase screws. And the multi-hole cup, you can put an anterior column screw also known as a kickstand screw. So we all know that the press fit cups take wedge purchase between the anterior column and the posterior column, and the dome is very important for the stability. But in dealing with acetabular fractures, many a times the dome is missing, or you have reconstructed the dome and you don't want to load that part. So you put a kickstand screw in the anterior part, and thus it helps in healing. Now here is a case of a comminuted posterior wall with a dislocation in a young male. We can all see the posterior wall is too much comminuted, and as a devout acetabular surgeon, I reconstructed in the best way that was possible. I used a recon plate over some spring plates. Now the fixation looks good. The patient went away. The fracture also united. But 8 months later, he presented with this X-ray. The whole of the femoral head was resorbed. Now we have to go for an arthroplasty, and this is what I did. I used a press fit multi-hole cup with the kickstand screw marked with the red arrow. Now the second technique that one needs to know is the impaction bone grafting technique. This is a very useful technique and comes handy in protrusio acetabular and many similar cases. So basically you impact morselized bone graft from the femoral head. Then you put a layer. Initially it was described for a cemented cup. So you put a layer of bone cement, then you put a polyethylene acetabular component. The bone graft can be prepared using a bone mill, or I use manual prep using femoral head slices that I take, and then I cut it with saw, bone cutters and nibblers. Now this is a case, this is not an acetabular fracture, it was a protrusio case. I filled up the area with bone grafts, and then I used one size smaller trial to impact the bone. Now this step is very important. Next, I use a reverse reaming with again a size smaller reamer to further impact and remove any gaps possible. And after that, I dry that part. Now, after this, you can feel if the base of the acetabulum that you have filled is stable, hard, or supportive or not. And then using standard position, that is in 40 degrees or 45 degrees or 15 or 20, whatever intervention you want, you put a uncemented cup. Now the cup is again wedged between the anterior column and posterior column and takes support from the dome. Now for a press fit, you need to, you want your cup to be completely solid with the acetabulum, and you can just move whole of the pelvis using your handle. So this is for impaction bone grafting technique in cemented cups. So this is another case, a ACPST type of fracture in a 50-year-old male. He was bedridden for 3 months. Now whole of the anterior column, this is all fragmented, and there is a large posterior column fracture. Now the CT scans were done and it seemed to be uniting. Already 6 months had passed. So we went ahead, we did an impaction bone grafting. This is the post-operative X-ray, and this is after a 1 year of follow-up. Next armamentarium is an impaction bone grafting using uncemented cups. Already described in my previous case. Similar case, ACPST, 12 weeks old neglected fracture. The column were uniting, but there was a central defect. We filled the defect and did an uncemented cup. Now coming to strut bone grafting. This is very useful when there is a large posterior wall missing. So we use the femoral head to fill that gap, and then we put the cup. Now figure of 7 bone grafting has been very well described. This is a very good utilization of the femoral head. We cut it in the shape of 7, and using two 4.5 or 6.5 cc screws, we can stabilize it in the ischial buttress area. Sciatic buttress area. And then we ream the cup and put the, ream the area and put the cup. This was a posterior wall defect with a femoral head fracture, again 2 months old neglected. And initially I fixed the fracture. After fixing the fracture, I saw that since the femoral head was missing from the inferior part and the hip was not stable in even 90 degree of flexion, so I went ahead and did a total hip arthroplasty. In this case, I used a figure of 7 head. And this is a 3 months follow-up of the patient. These are similar cases where I used a screw along with a plate over the posterior graft. Now coming to trabecular metal augments, every one of us are using these kind of augments. It is now readily available in our state, both the augments and the cups. And these trabecular metals are made up of titanium and tantalum. They are highly porous. Almost structure is like a cancellous bone with excellent ingrowth properties. They have better strength than allograft, and there is no resorption. Now these can be, these come in various designs and can be used in multiple ways. This is a case where an augment was used. This is a 2 month follow-up, and then again a 6 month follow-up. Similar case using tantalum cups with a 2 month follow-up. Just I'm closing up. One can use a vestibular cage construct. This is not biological, but it provides some kinds of ingrowth possibility. And you put a cemented cup over the cage. And there is again a cup cage construct, which is more biological than the cage construct. Now there are triphalangeal cups that I have never used. These are internet pictures. You can use custom-made vestibular cups, and there is a coned hemipelvis that takes purchase in the sciatic buttress area and can be used. So our take-home message is that pelvis plating set should always be available in the OR. Keep multi-hole cups handy. Always evaluate the CT and contemplate the bone loss. Order for augments or cage beforehand. Be very well versed with the impaction bone grafting technique, and always start surgery with an empty bladder. Thank you. That is empty bladder for both the patient and the surgeon.
So wonderful cases, as always. Wonderful surgeon that you are. This is nothing less as expected of you. So have you ever used, must have, because you have not mentioned here, that's why I'm asking, must have used it, the iliac crest, a big chunk of iliac crest instead of just the way you showed your figure of 7 from femoral head?
No, it's from the femoral head. There are 3 scenarios which we use our grafts. First is when you are doing an acute THA. So you have the femoral head available with you. But if you are doing an post-operated case, then many times the femoral head is not very good quality. Then you have to rely on iliac crest grafts.
Right. One of your X-rays showed the femoral neck as if you have done a osteotomy.
Osteotomy?
No, you haven't.
Huh.
The X-ray, the pre-op X-ray, it's a fracture. No, the head resorption is such that it is almost like
It looks
Be-
like a fracture.
because
yes,
it
sir.
is watershed line,
Yes,
right?
sir.
So the comment I want to make that if we incorporate the use of 3D planning, 3D printed models, sometimes it helps you understand what exactly is inside. Probably you'll be better prepared. So would you agree with that thought?
No, sir. I definitely agree with the point that 3D planning is very helpful in a stubble reconstruction. But even the 3D CT scans, if you have those on your computer screen, you can just remove the parts you want to see. You can rotate the pelvis, and you can see all the bone defects very well. But definitely 3D planning has a very good role and being used globally also.
And today we have a talk on 3D printing. How can we avail its advantages? One of the doctors has come from Bangalore. He's going to speak.